Good afternoon and welcome, everyone. Thank you for joining us. My name is Thomas Levis. I'm Dean and Weatherhead Presidential Chair at the Tulane University School of Public Health and Tropical Medicine. I'm also Principal Investigator of Partners for Advancing Health Equity, or P4HE. I'd like to welcome you all to today's webinar. Based at the Tulane School of Public Health and Tropical Medicine and supported by the Robert Wood Johnson Foundation, Partners for Advancing Health Equity is a national research learning collaborative that aims to bring together various sectors, including government, academia, civil society, philanthropy, and the private sector, to harmonize efforts towards health equity and promote actionable solutions. One of the ways we do this is by providing interactive spaces for activities like today's webinar on the economic burden of racial, ethnic, and educational health inequities in the United States. This webinar is based on the recently published JAMA article by the same title and brings together some of my fellow authors and top public health experts from academia and government to dive deeper into the most recent findings and answer your questions about them. Our goal is to convey this knowledge in a way that is useful for all of you. So as we get started, I'd like to ask our audience to share on the chat where you're joining us from and tell us about the work that you're interested in health equity. Please continue to share your thoughts as the webinar progresses, and use the chat to ask questions. This initiative, the Economic Burden of Health Inequities, was established back in 2007 during the congressional discussion and debates around the Affordable Care Act. The team that I was a part of got the idea that we needed to create additional arguments in support of provisions that was attempting to address health equity. Most of us, probably everyone on this call, came to an understanding of the importance of addressing health equity on the basis of the compelling social justice argument. That is, that we don't want to live in a society with inequities. However, we thought that there was an additional argument that could be made, an additional impact that health inequities has on the society. And that impact is in the economy. And in that way, health inequities impacts everyone. We did the initial analysis in 2008 during the debates around the Affordable Care Act, which we understand was used by advocates for the Affordable Care Act to make arguments for the additional provisions to address health equity in that bill. And over the years, we've updated this work and conducted additional analysis, not only on the US economy, but on several states and cities. This current effort to update this project was supported by the National Institute on Minority Health and Health Disparities of the National Institutes of Health, and this focuses on health inequity and the economic impact on the US economy and the impact on various states. We'll have a presentation of the findings from my co-author, Dr. Daryl Gaskins. Dr. Gaskin is the director, as the William C. and Nancy F. Richardson Professor in Health Policy and director of the Hopkins Center for Health Disparity Solutions at the Johns Hopkins Bloomberg School of Public Health. He is a health services researcher and health economist who is internationally known for his expertise in health inequities, access to care for vulnerable populations, and safety net hospitals. Daryl will be followed by remarks by Dr. Eliseo Perez de Sebeli, who is director of the National Institute on Minority Health and Health Disparities at the National Institutes of Health. He oversees NIMHD's annual budget to advance the science of minority health and health disparities research. And welcome to both of you. Daryl, I'll turn it over to you for your presentation, followed by Eliseo's remarks, and then we'll have a Q&A with the audience.
Thank you, Tom, for that kind introduction. And it's a pleasure to have worked on this particular report. So I'd like to talk about and present this the findings from this study, the economic burden of racial and ethnic and educational health inequities in the United States. Let me first say that I don't have any conflicts of interest for in this report itself. And I also want to acknowledge our co-authors, which include the three of us, but also persons who are on staff at the National Institute of Minority Health and Health Disparities, as well as persons, teams at Tulane and Uniformed Services University and the National Urban League. I also want to acknowledge the expertise, insightful comments of a real strong technical advisory panel, which included health economists, social epidemiologists, demographers, and really just helped us make this science really very good. So first, I just want to begin with talking about what health inequities are. Health equity we think of as everyone should have a fair and just opportunity to be as healthy as possible, and that obstacles such as poverty, discrimination, unemployment, education and housing, the environment, and then access to healthcare should not hinder people's opportunity to be as healthy as possible. And so we think that society should organize itself in such a way that we eliminate health inequities. Now, many of us are familiar with this quote from Dr. King, which says that of all forms of inequality, injustice in health is the most shocking and inhumane. So you could decide that you want to address inequities because it's the right thing to do. But we also want to point out that it's also the economically responsible thing to do too. So if you won't listen to the preacher, maybe you'll listen to the statesman. And the statesman says, hey, an ounce of prevention is worth a pound of cure. So let's invest in prevention. Now, the message and the underlying message of this is that social justice should be enough, but injustice, it has a very hefty price tag. And when we did this analysis some years ago, we found that over a 4-year period, the U.S. economy lost in terms of value $1.2 trillion with regard to the impact of racial and ethnic health inequities. And $1.2 trillion, just to put it into context, is about the size of the economy of India, which is the 12th largest economy in the world. So it's a lot of money. There have been other groups that have looked at this, in particular, Daniel Dawes and his team, while he was at Morehouse School of Medicine, looked at the cost of mental health inequities. There's this report by Davis that looks at the cost of health inequities attributable to the U.S. healthcare system, $320 billion today, $1 trillion in 2040. So our study updates our analysis that we did looking at the nation first in 2007 and then in 2004. So this looks at 2018. And what we do here is in addition to looking at the racial and ethnic inequities, we also look at educational inequities also. So what are we trying to do? So we are looking and encouraging society to achieve health equity. And health equity is a little different than health disparities. And why health equity? Why focus on health equity? Because it does a number of things. One is that it gets us out of the comparisons between populations. which moves us away from looking at treating society as a zero-sum game. The other thing is that it also allows us to appreciate the resiliency within populations that are experiencing disparities and try to learn from those things. And then it also moves us away from this notion of minority pathology, which is that there are some broken people out there and how such more focus on systems. So this analysis itself, it does a number of things that improves on the other analyses. In one, that it includes Native Hawaiians and other Pacific Islanders and American Indian Alaskan Natives in our population, as well as we do a calculation for white non-Hispanics. And then we also do this calculation with regard to educational groups, looking at persons who don't have a high school education, a high school degree, and some college educated persons. So when we're asking, okay, well, what is it that we're comparing our current health status to? It's to these health equity targets. And this sort of follows the rationale that is used to think about healthy people 2020, healthy people 2030, in that there are targets that the United States population should reach in order for us to really achieve and improve the health of all of our people. So the way in which we express those targets is that we say that what we like every population that we're looking at to have is the prevalence rate for 13 health conditions, and you can see the conditions on the screen, for the person at the 10th percentile. And so if the population is at the 10th percentile for in terms of risk profile, then that would be achieving health equity. And then we do likewise for all-cause mortality for each age group. We're looking for every population to reach the all-cause mortality for that particular age group at the 10th percentile, which is whatever state is ranked 5th in the nation. Health inequity costs are broken up into 3 groups: excess medical spending, lost labor market productivity, and the value of premature death. And we do this calculation for both the nation as well as for each state. There are other costs that we don't calculate that could be considered. So we could think about the impact of mortality on families and caregivers. We could think about the cost of non-medical services, lost tax revenue, reduction in business activity. Those are things in which are not necessarily included in our cost estimate. 2 main databases that we're using: the Medical Expenditure Panel Survey and the Behavior Risk Factor Surveillance Survey, which we use to do the state level analyses. And then for the premature death calculations, here we're going to use the National Vital Statistics Survey in order to compute death rates. So the analytic approaches is that excess medical expenditure and lost labor market productivity is really an incremental cost approach analysis for those of you who are methodologists or economists out there. And the premature death cost is associated with a willingness to pay or value of statistical life. So jumping right into the findings, one of the things that we found is that for the total health inequities for non-white populations is $421 billion in 2018. And you can see that a large percentage of that cost is associated with the Black population, although I also would point out to you that the American Indian, Alaska Native, as well as the Native Hawaiian and the other Pacific Islander populations have a disproportionate share of the cost relative to the size of their populations. The other thing that I would point out is that the white population is not reaching these health equity targets also. And those populations, the cost associated with their not reaching the health equity targets is $600 billion. So other interesting things about these national, or I should say, when you do these calculations on the state level, looking at race and ethnic, they do vary by state. And I would encourage you to pull out the tables in the paper and look at your individual state. We would like people to look at these numbers and compare them to what the states are spending relative to address health inequities in their particular state. But you can see that depending upon the race and ethnic group, Texas, Native Hawaiians, and Pacific Islanders have a large health costs associated with health inequities. Minnesota for American Indian, Alaska Natives. Missouri for the Black population. Maine, of all places, for Latinos, and New York for Asians. When we look at the expenditures for education-related health inequities, here we find that the cost of health inequities for persons without a four-year college degree, $940 billion, very high. And that the high school, persons with a high school diploma or GED have the majority of that expenditure, but persons with less than a high school diploma, I should say less than a high school education, have a disproportionate share. The other thing that we should note is that the cost relative to persons with a four-year college degree is $35 billion, which is relatively small relative to the total cost of health inequity. When we look at what's happening at the state levels, South Carolina is a place where persons without a college degree, a four-year degree, experience a lot of health inequities. And as a result, the costs are significant in the state. And Kentucky for persons with less than a high school diploma. Finally, I just want to give a sense as to how these costs are associated with the size of our economy, to give you some context. So in terms of racial and ethnic health disparities at $420 billion, we're talking about something that is akin to 2.2% of GDP. And you think about that, that's almost wipes out the growth of the economy in 2018. And then when we think about the cost of education-related health inequities, 4.7% of GDP, which is twice the growth rate. And then when we compare these costs by states, there's some states where the cost of health inequity is a large percentage of the state's GDP. In particular, I'm thinking of Mississippi when it comes to racial and ethnic health inequities, and South Carolina when I'm talking about educational related health inequities. So we would encourage people to use these numbers. The social justice argument should be enough, but for some people it's not enough. And since it's not enough, we bring the economic argument and said, but it's to do nothing costs us a lot of money. So I will stop there and give my colleagues a chance to chime in with regard to conversation and discussion.
Thank you for that overview, Daryl. Eliseo, we'll turn to you for your reaction.
Right. Well, I was part of this project, so my reaction is it's great. It's a great study. So let me just reflect a little bit from the perspective of NIMHD and NIH, the research entity. So first of all, from our sense at our institute, founded beginning of the 21st century, race and ethnicity, this self-identified construct that we use loosely, and socioeconomic status, social class, however we measure it, educational attainment, I think is a good way, are really the pillars of the science that we do. And one of the reasons we wanted as an institute to redo this analysis that had previously been done was to put this in economic terms, because we make the social justice argument, we make the advancing health, improving health is good for humans, and that's what we do as clinicians, as scientists, as public health leaders. But we also acknowledge that it's important to put this in economic terms, because, you know, after all, the government has a big budget. That's how the capitalist system works, and so we don't want to put a price on equity or devalue. But this is, I think, an important policy side. In preventive medicine, or in thinking about when should we value a screening test, people always used to talk about, well, what does it cost per years of life saved? And if we used to use the dialysis as the sort of the gold standard, you know, it was $25,000, $30,000, $50,000 per year life saved. Maybe that's gone up to $100,000 now for approving it. And here we're talking about $450 billion per year. So the dimension of the problem is quite high. So getting back to the issue of race and ethnicity, the progress in the last 20 years has really been modest. For example, we saw the premature mortality standing out for African Americans, and although much smaller population for American Indian, Alaska Natives. And there was progress for African Americans, significant progress in between early 2000s until about 2012 or so, but it has kind of flattened. And we know the pandemic put us all behind in these last 3 years, although there's optimistic signs that we recover some of that. And for Latinos, Hispanics, you notice the premature mortality toll is much smaller because premature death, you know, Latinos have a longer life expectancy and have generally done better. For Asians, the excess premature death cost was zero. But there was excess medical care costs, lost labor market. Latinos have the highest rate of uninsured of any racial and ethnic group in the country. This after the Affordable Care Act, it was reduced to 20%. And generally for white Americans, it's well under 10%. So we think that in thinking about research, one of the areas that really needs emphasis, of which NIH has to some extent shifted more resources in that direction, is implementation science. What can we do to actually implement, do the things we know work to make outcomes better? Now, people talk about controlled blood pressure, controlled diabetes, better prenatal screening, decreased maternal morbidity. But in this case, this is a goal of equity. Can we get health systems to say, what does our profile look on an equity lens, that is by social class and race and ethnicity? Do we get the same readmission rates? Do we get the same mammography screening rates? And do we get the same blood pressure? So not just overall, but also look at it this way, because that's where the gaps really are. And then think about multi-level ways of intervening. I'll end by saying just a couple more things. First, the diversity of the workforce is a known way that we can make things better. When we train more clinicians of color, they practice in underserved areas. They see more patients who we're talking about here, and yet we are way behind on this and not making progress. We think scientists who come from underrepresented groups also are more likely to be doing this kind of science. And we know diverse teams do better work. We need community engagement. We need to connect to our communities so we understand more about this. So together we can make progress on this. And finally, I already mentioned the implementation issue. More and more data are being collected, and there's a whole field that's exploded in data science. Now we have artificial intelligence, machine learning, and our scientists, people who are interested in health equity and health disparities, really need to have that on their front burner to see how can we leverage existing data to really advance our knowledge, make discoveries, and implement interventions to make this whole situation better. So I'll pause there and pass it on to you guys to comment.
Okay, thank you so much for that. We ask that if you have any questions, please put them in the chat. We're monitoring the chat for questions, and I'll ask them. But I have a few questions I'd like to ask. So, and this is to either of you. So first, is it correct to say that the economic burden has increased since the last study? Can we directly compare this study to previous studies, and if not, why?
Well, I think the short answer is no. And the reason why is because this study improves upon the prior studies in so much that it includes Native Hawaiians and American Indian Alaska Natives. It also, the prior studies used sort of the best in cohort, the health status of the best in a particular cohort as the target, as opposed to our health equity targets. Now we try to do some sensitivity analysis around that to see how those things impacted. I think the way in which we've done it, obviously, if you include more populations, you're going to increase the number. But in terms of the way in which changing the health equity targets, I think it's probably a more conservative approach in terms of what the targets are, as opposed to using the best in cohort. So I would discourage people from just sort of saying, oh, well, in 2014, you estimated this, in 2018, you estimated that, and thinking about it growing, because we do know, as Eliseo pointed out, there have been some improvements, and we don't want to overshadow the work that people have been doing for the last, ever since, I guess, unequal treatment come out, to improve health. I mean, life expectancy for African Americans had been improving, and the gap between whites and blacks were narrowing, and so that would have an impact. So we don't want to give the message that there hasn't been any progress. There has been progress. It's just that it's still, the health inequities are still very costly to our society.
Okay.
If I may add, I totally agree. I think comparison methodologically is challenging, but this study puts another lens on the issue, which I think is really important for both policy reasons and systems issues. And for example, an area that we're continuing to expand, as we know, is to think. We showed the data for the states, which can be amorphous, big, or, how many Latinos live in Maine, just to highlight that one. But when we get to the county level, then we really can get to action at the local level, and see how different areas compare. Just like the HIV and the HIV epidemic looked at hotspots across the country, we know now in certain parts of maternal morbidity, mortality, there are certain areas of the country where we really should be focusing on. It's not the entire country, it's certain areas. I think the same thing can be done with these data.
Okay, so I think it's we're saying we should be careful about making that comparison, which I've seen some people make, but we want to discourage people from saying that the burden has increased because the number is bigger this year than it was the last time that we did it. Another question that we get often that I want to address and put on the table is, we're often asked, well, when someone dies, they pay into Social Security for years, and then they die before they're able to collect. Doesn't that save money? So doesn't the premature just actually save money to the economy? How do we respond? How do you respond to that?
Well, death does not save anybody money. At best, what it does is just gives heirs money, but it doesn't save money. Your Social Security tax, your Medicare tax is not going to be reduced because someone died. I think of it more like this. If a company lays off 10,000 workers in a town, that company actually might save money on on its payroll because they no longer are employing those 10,000 workers. However, for the town, it is a disaster. And why is it a disaster? Because there are 10,000 people who aren't working anymore. And that's 10,000 people who don't have money to pay their rent, to pay for their utilities, to go shopping in the town. And so all the business community loses, even though that one company saved money, all the entire business community in the community loses because now all the economic activity that those 10,000 people were engaged in goes away. And so when someone dies, and it's not just the emotional loss, it's sort of like all the things that that person was doing and contributing to in our societies. 50-year-old man passes, 40-year-old woman passes. All the activities that they do now and that they would do just goes away. And it goes away, and there's a value to that activity that we appreciate. And so we valued it at $100,000 a year, but some people would say that it's priceless.
Okay, great. That's a couple of questions that we get often. I thought I'd put it on the table and address it. Eliseo, did you want to add anything there? Or if not, I'm
just that the model said premature death, not just death, right? So I think Daryl emphasized that by the examples.
So the data for this study, we use data from before the pandemic, the COVID pandemic. I'd like to ask you to speculate on what you think would be the results if we did this for the years 2019 through 21. Do you think what do you think would be different about the results?
Well, I'll just jump in, and we know that for African Americans, Latinos, American Indians, Alaska Natives, the pandemic was disproportionately burdensome, not just in cases, but in hospitalizations, so in excess medical costs there, and deaths by a factor of 1.5 to 3, depending on when you took the snapshot. We also know that over the course of about 2 years got dramatically better, in part because our communities were vaccinated at a higher rate, at a rate that caught up to the general public, maybe a little bit behind on the American Indians. So, and that the recovery of the lost life expectancy that was documented after 2020, I would expect some of that or most of that to be recovered, but I don't know yet. We have to wait and see what develops. So I think if we did this for 2020, 21, 22, we would see dramatic worsening of the higher burden of cost from this kind of analysis.
Mm-hmm. So a question we have from the audience, what are the opportunities for drilling down the study to regions like zip codes or even health system catchment areas?
Well, one of the challenges in doing a calculation like this is that you need to have good epidemiologic data. You got to be able to compute reliable estimates for mortality, true death rates and then you also need to have prevalence data. And so the likelihood of trying to do this for a zip code or for a census tract would be very challenging because you're only as good as that data allows you to be. Now we have a study, we're currently doing an analysis looking at counties, and for counties in which we have large enough populations where we're able to calculate good rates, prevalence rates and death rates, we're able to do calculations for. So I think that's really sort of the limiting factor here is the quality of the data.
Mm-hmm.
But I want to reemphasize that this would be a great thing to lead to, and as we're involved with other studies looking at sort of geographic distributions, because these inequities don't all affect all areas the same. Again, use the example of Latinos who live longer, have better outcomes, but when you look at certain parts of the country, and this is from other studies, the Four Corners or the border, things aren't so great for Latino Hispanics. And so I think this is the kind of analysis that we need to be able to then say, okay, the local, this is where we need more resources, or we need to activate, implement what we know may help reduce these inequities. So.
Mhm.
So another question from the audience. Are there similar studies that incorporate disaggregated data for the Asian population?
I think the short answer is no. But I was sort of thinking about that question as to where you could possibly do that. So I think you probably could do that in California because they have data systems that would potentially support such an analysis. You possibly could do it in a place like New York City, because they have data systems that could support it. You wouldn't necessarily want to do it nationally, because I don't know if our death rate data, we probably could do something, but it's the prevalence data, because that's based on surveys, and so you'd have to have enough individuals in the subgroups to and actually compute asthma rates, heart failure rates, hypertension rates, diabetes rates, and feel comfortable with those numbers.
Yeah, I would add a comment. Yeah, I agree totally with Daryl that California and probably New York City or parts of New York you could do this, but we get into big sample size issue. I mean, it becomes almost impossible to really have small populations. You suppress data when it's a small number of events in a particular area, so it gets really challenging, both from a research ethical and methodological perspective to do too many subpopulation analysis. But in general, we know Asian Americans, the biggest thing was to separate out the Native Hawaiians and Pacific Islanders. So doing the Asian and Pacific Islanders together is wrong. And one of the lessons from this is we really have to look at them separately all the time for health outcomes, because Pacific Islanders and Native Hawaiians generally have higher rates of certain conditions, and higher mortality rates and lower health insurance. Despite the heterogeneity of Asian Americans, they do tend to have higher rates of insurance, higher household incomes, and better health outcomes than even the Latino Hispanic community. These are, if you pull together East Asians, Southeast Asians, and then South Asians, the people from Southeast Asia, so Vietnamese, Filipino, Laotian, will tend to be the ones who are most likely to have disparities based on local data from California or regional data from California. So,
Alicia, we have a question specifically to you. Much of the research needed is within the purview of AHRQ or PCORI. Could you discuss the NIMHD and NIH's collaboration with these agencies?
well, PCORI, I don't think we use data from PCORI. Most of the data was the Medical Expenditure Panel Survey and then the CDC data on the National Center for Health Statistics, mortality data, and the Behavioral Survey from the CDC. So we work with our federal partners all the time. Sometimes there are more barriers than you would expect, but we try to pull in the same direction frequently with our own initiatives. CDC collects a lot of data, and we often are eager to get access to that data. I think that this project is a great example of how that can be leveraged with NIH funding and extramural scientists to be able to do this. And we have another project, and other institutes do the same thing. I think in terms of health services research, that's what HRQ's major area is. And all of these agencies, including NIH and the ones that have been named, are interested in promoting health equity and decreasing disparities. So we try to collaborate on these aspects as much as possible.
Okay, thank you. How do you think inequalities with regard to access to insurance can be addressed practically in the U.S.? This is from someone who says they're from the UK.
Well, that's an opinion. So my own, I would say this is my own personal opinion, not representing any position of NIH, which is that, we passed the Affordable Care Act in 2010, and part of the mantra, at least as it was embraced on the west part of the United States, which is very different than the east. Having lived now in both ends here, I can see the difference. Was to create these accountable care organizations that would sort of take on the idea of, we're going to take care of a population. And so it starts with that whole idea that you're not on a fee for service, sort of come see me, I'll see what's wrong, and then we'll take care of you. They're thinking in terms of taking care of a population. That would be a culture shift for healthcare providers, for systems, for clinicians. And look at our metrics based on, how many lives are we covering? And this is where the staff model health maintenance organization came out of, the Kaisers, the Puget Sounds, the one in Detroit. This is one way of approaching it. And then you could say, well, the university also has an interest in this, and they said, we're going to play in this field. And then you had the private sector, the Sutter Health System in Northern California did this, and then the public sector were. And so I could see it evolving in that direction and say, hey, there's potential here. And then everything kind of stopped in 2016, 17. And now we've kind of been stalled, I would say. There are some efforts to reignite some of these metrics, but of course the pandemic got in the way, and there are other issues our country's dealing with. But I can sort of envision a system where we channel the resources in that kind of a way. And of course, we have to deal with things like the disproportionate compensation for executives, the way insurances work differently, things that drive clinicians crazy is, okay, I'm going to have you see a specialist and then have to go through 15 hoops in order to get someone to be seen, or gets denial of a test, all these things that make our health system so inefficient and inequitable. So this is my opinion. As a former primary care doctor.
Yeah, I think we need to be committed to providing health care to all persons who live in the country. That means both persons who are citizens as well as persons who are not citizens. I always say to providers, I say, we expect that when someone who is sick presents themselves at a hospital, that the hospital takes care of them. We expect that. And so it's not about whether we're giving something to somebody who is a non-citizen or somebody who isn't working or somebody. It's about whether we're going to pay the doctor, whether we're going to pay the hospital for the service that we expect them to get. Because none of those other folks are walking around with checks from Medicare or Medicaid, none of them. So it's about how are we going to pay physicians and other healthcare providers for providing the care that we expect them to provide as being a civilized society. So all this stuff about undocumented people shouldn't be included, or that there are certain poor people who don't deserve coverage in Medicaid, or certain people who work. All that stuff is nonsense in my point of view, in my opinion, because none of those people get a check from any of these programs. The only people that we pay are the people who provide the care. And so we should be, as a society, willing to cover everybody. And until we get to that place and say we're going to stop being, in a real sense, it's in some ways it's selfish, that we're going to stop thinking that there are some deserving poor or people who deserve to be poor who shouldn't be treated, then we're going to have problems with inequity, because then when we don't treat them, when we don't provide them with the care, then what happens is they have higher levels of chronic diseases, they have premature death, and it costs the entire society for in terms of lost GDP.
Well, yeah, Darryl, as a society, we haven't said that we expect everyone to receive care. We tie access to healthcare to health insurance, and we tie health insurance to employment, which is the most bizarre thing in the world, if you ask me. We're the only country that does it that way. We had states had the opportunity to expand the Medicaid program to ensure more of their populations. You had the states with the largest minority populations and the highest poverty rates were the states that refused to expand Medicaid. They refused to take the federal dollars to do that. And those states, residents of those states, Georgia, Arkansas, Mississippi, pay federal taxes that were used to expand Medicaid in other states, such as Louisiana and California and New York and Maryland. But as a society, this is what we've decided to do. North Carolina just expanded, but they added so many work requirements that essentially they said, if you're not working, you still don't get access to healthcare. This, it seems to me, is the value of this society, not the expectation that everyone gets access to healthcare.
Well, I would say there's a cognitive dissonance going on because we expect that if those persons show up in the emergency room with a broken arm, they're in a car accident, we don't tell the physician, oh, well, you can just do a wallet biopsy, figure out whether they have insurance, and if they don't have insurance, you can just set them on the street. We have laws like EMTALA that says you got to treat this person. You have to provide care for this person. And we get appalled when news people come out and show and say that the doctor or the hospital does not provide care for this person. And then so we're, on one hand, we're doing these things with regard to insurance coverage, but on the other hand, we have this righteous indignation when we don't think physicians are behaving the way in which we expect them to behave because they're of their profession. So that's why I said, so we should either, I should say, we should decide to be the people who say we want our physicians to treat people who are sick and then give them the resources to do that and stop nickel and diming folks and saying, well, because you're this or that, you're this, you're that, you can't be covered.
Okay, I'll go back to being a moderator and not comment, which is not an easy thing for me to do. So I'll try to stay as a moderator. Okay, how do you use this research to provide incentives for equitable care and development of population health dashboards to transform the healthcare systems and individual provider EMR systems? Let me ask it differently. How can we use this research to impact healthcare, the way that we organize, pay for, and distribute healthcare?
Well, I'll start. I think this study or this analysis reinforces what we already knew from the epidemiology and clinical outcomes. If you have differences in heart failure by race and ethnicity or socioeconomic status, health systems should be considering looking at that and create a metric of how good are we at health equity. So let's give the example here. I gave it earlier of readmission rates, a big cost item for health systems and Medicare in particular. And we can say, well, the standard should be below, arbitrarily say 15%, just 30 days, readmission rate for a particular condition. In the case of heart failure, one of the most common reasons for people being in the hospital. And if it is 18% for African Americans and 12% for whites, well, that's something the system should be addressing. What can we do to make those, come together or bring down the African American rate so there's equity and the good things that we have accomplished with the white patients? And that's an example. And the same thing could be done through Medicaid versus non-Medicaid patients, private insurers versus public insurance, or the Medicare Medicaid, which is the Medi-Medis, which are patients who are generally poor. And this reinforces what we already know from the epidemiology, that poor people have more disease and have worse outcomes, and people primarily people of color have disproportionate burden of certain diseases that lead to worse outcomes. So I think that we're moving in that direction. There was a comment in the chat I saw about social determinants of health, which has been something that some of the health insurers have jumped into. But it starts with the very basic ones, you know, the demographic ones and the socioeconomic one, as opposed to all the other ones that people are addressing, whether it be food, transportation, or safety or housing. So.
Yeah, I would just like to add that, you know, the lost labor market productivity numbers imply that the cost is spread among employers, and they're experiencing in terms of absenteeism, sick days, people not being presenteeism, being able to work as effectively as they would like to. And so they should be challenging the health plans that are providing their employees with health insurance, with programs to help them do a better job in terms of addressing hypertension and diabetes. If people are pre-diabetic, maybe making sure that they get enrolled in diabetes prevention programs, trying to do things in order to keep the workforce healthy, as opposed to just being agnostic to it and not doing anything, and then expecting that by the time when they do get sick, then the healthcare system's going to pick up. One other thing I just would like to say is about, you know, a lot of, you know, the high school numbers and the less than high school numbers. I mean, jobs, the way in which we have structured jobs for those individuals is that those people are under a lot of job stress. They can't control when, I mean, some of them can't even control when they go to the bathroom. And so we know from the Whitehall studies that if you put people in jobs with job stress, you're going to get chronic conditions later in life. I mean, it's just, we know that from those studies. And because of that, employers need to think about the way in which they structure jobs for people who have less than less than a 4-year college degree, giving them more autonomy, giving them at least the ability to, if they needed to go to the bathroom, they can go to the bathroom. I mean, so it's those kinds of things that we also need to think about.
We have a research-oriented question I did want to get in. When operationalizing economic burden, what was the rationale for excluding other possible costs, for example, lost tax revenue?
Well, we didn't exclude lost tax revenue in the sense that we didn't compute it. We could potentially have taken what we call the lost wages, essentially, and then begin to think about what the tax rates are associated with it federally, as well as on the state level, to make that kind of calculation. So I would suggest that, I mean, they wouldn't increase the cost of lost labor market productivity, but they would be a subset of those costs. If I just sort of thinking through the exercise.
So as we're coming to the end of our time, but I wouldn't want to give each of you an opportunity to make any last comments that you may have about the project or anything that maybe hasn't come up in the Q&A.
So I'll go. I'll go first and let the director have the final word. I just would say that health inequities are just costing society too much money. And so if you're working in this space and someone comes to you and tells you that the intervention that you're proposing is costly, and therefore we don't have enough tax dollars to do it, we don't have enough resources to do it, we don't, tell them that the cost of doing nothing, there is a cost to doing nothing, and that cost most likely exceeds the cost of whatever program that you're trying to implement.
Okay, thank you. Director.
Reiterate the big picture here. $450 billion is almost 10 times the NIH budget. And of course, NIH does research, not implement programs necessarily. So if you think about 10% of that And if we invest that on an annual basis to try and address these inequities as a country, can we decrease that burden and actually in the long run save money, have healthier population that goes on to do great things for our country. And I think that's where the big message is. Drilling down on the local level, I think, is hopefully the next step, so that we can say we're not just going to make well people better, we're going to really get at the people who need it the most.
Okay. Dr. Eliseo Paris-Desebeli and Dr. Darrell Gaskin, thank you both.
Thank you, Tom.
Now, as we close this seminar, we'd like to learn from you about how practical and applicable to your work these conversations are. So I'd like to invite you to fill out a short survey that you should be able to access through the link in the chat or by scanning the QR code on the screen. Now, with that, we conclude our session today and invite you to join us for our upcoming events. On Wednesday, January 24th at 12 p.m. Central Time, we continue our newest workshop sprint series titled Design Thinking for Design Justice, led by experts in design thinking. Register by scanning the QR code on your screen or by following the link on the chat. Also, mark your calendar for February 20th at 1 p.m. Central for our first webinar for 2024, Expanding Health Equity Beyond Public Health. Please stay tuned for more details. More information about our upcoming activities is available on our website, which is partners4healthequity.org. And follow us on social media and help us spread the word by sharing our content that most interests you and your work. Thank you for joining us today. We'll see you soon.